You're listening to the Dr. Geo Prostate Podcast, where real talk meets real science to help men take charge of their prostate health. In today's episode, Dr. Geo talks with Dr. Joseph Pinzone, Chief Medical Officer at the Hypothermia Cancer Institute in Irvine, California, a Harvard-trained endocrinologist with over 20 years of experience in tumor biology and patient care. Dr. Penzone explains how non-invasive, FDA-approved hyperthermia therapy is improving outcomes for patients undergoing chemo, radiation, and immunotherapy. Now, let's get started.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Podcast, Dr. Geo Prostate Podcast. We made that transition recently, and I just keep forgetting the prostate part. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, where it is my intention to help you with all sorts of prostate problems, malignant, benign, even if you don't have a prostate, how to reduce the risk of recurrence and all those things, and all sorts of other male things, testosterone, erections, and even how to live better with age. And today it's such a great pleasure to introduce to you, and you heard much of the bio earlier, Dr. Joseph Pinzone. Nice to see Penzone. Such a great Italian name. You know, it's embarrassing considering that though I'm not Italian, my name is Italian, Giovanni. Mm-hmm. All my kids' names are Italian for some reason. It's not like we planned it that way. I grew up near Little Italy in the Bronx, and I worked in an Italian restaurant for about 10 years through college and through grad school and through medical school. So I should have these Italian names down right by now. Anyway, thanks so much for being on, Joe.
Sure. Oh, my pleasure.
All right. So we're going to talk hyperthermia here. And I did have it's going to be published prior to yours, I know, another expert that I had, Dr. Palmer. And while there's going to be a little bit of an overview, which is worth repeating, and certainly have your intake, we certainly going to focus more on what it is that we can do here in the United States that perhaps we cannot do in other countries as it relates to hyperthermia. Now, before we begin, some touching points. Don't forget to go to the drgeo.com, Dr. Geo newsletter. There's a lot of information that I send via email once or twice a week that you're not going to get anywhere else. These are what to do, how to do things, the latest and greatest in all things related to holistic and integrative urology and so forth. So make sure you go to drgeo.com and sign up. My first question I have to ask, Joe, is why you chose the road less traveled. You're an endocrinologist. You could have had an endocrinology practice somewhere. You're out in California. Why hyperthermia?
Yeah, I think it's a lot of people's answers in life. Serendipity, really. I mean, it was one of those things where you're right. I am trained as an internist and an endocrinologist. Now, I know a lot about tumor biology for two reasons. First, I am the primary doctor for most patients with thyroid cancer. An oncologist I don't do the surgery, but I would send them for surgery. I don't do the radioactive iodine, but I would send them for radioactive iodine. So I know about certain endocrine cancers. In addition, I had an NIH-funded lab when I was in academia for about 10 years, focused on a particular signaling pathway that helps breast cancer cells metastasize to bone. And so I was researching that pathway for about 10 years. I always ask myself, how did I end up in endocrinology? And not that I love it intellectually and clinically as well. On the other hand, you can think of it as the normal communication between cells, right? Cells communicate either electrically like neurons, but mostly it's chemically. Mm-hmm. And so these are signals that can act as growth factors for cells. And I really just enjoy the understanding how chemicals and systems work inside of cells. But I really like the intensity of dealing with patients who have immediate critical illnesses. And I think that led me to a very niche area. And the story is that I met my partner who has the technology to do the hyperthermia, and we became very good friends. And we decided to partner to be able to let me deal with the medical aspects of administering hyperthermia. I had heard about it back when I was a resident at Columbia during a grand rounds, and then it never really caught on in this country. And I think I know why. We can talk about that if you want. But it's kind of just happened to meet my partner by happenstance and thought this is a really cool thing that really should not have been left by the wayside because it's FDA approved.
Mm.
It's paid for by insurance, but most insurance, I mean, not every insurance, but most insurances will cover it. It's FDA approved to be used in all solid tumors. I know we're going to narrow our focus to prostate cancer, but it's in all solid tumors with chemotherapy or with radiation therapy. And it is one of two modalities. We use ultrasound. And then there's also a microwave machine that's also FDA approved in this country. So there are two types. And now other people claim to be doing hyperthermia and they may be doing some sort of treatment, but there's only two technologies that are FDA approved in this country. And I thought, wow, what a unique way to contribute to something and get that increased intensity of dealing with patients who are really dealing with more immediate life and death issues on a regular basis.
You know what's the irony here? That the first time I heard about hyperthermia was about 10 years ago, also in a grand rounds. Not at Columbia, though I trained there for 5 years, so we might have missed each other. But at NYU, about 12 years ago. I can't remember the gentleman's name, but I wonder if you know. He was at Duke. He was a Duke professor. And there can't be too many academic people teaching about hyperthermia. In any event, he gave a presentation. And at the time, it was like, okay, we're studying this to see its role on prostate cancer. And it sort of never went anywhere. Because here we are, fast forward 12 years later, it's not a standard of care, though it is,
Right.
as you said, FDA approved.
Right.
So, and I became super intrigued because to me, it was like, wait a minute, this sounds, so I'm a naturopathic doctor, naturopathic urologist, do prostate cancer. It's the only oncology I do. I said, wow, this sounds up my naturopathic alley. And then, so nothing came out of that. And certainly I haven't seen much research there, which begs my next question. And I did have that conversation with Dr. Parmar. What's happening? Why is it that the technology has taken so long to be widespread use and approved? Is it simply just, Dr. Parma would say, there's not enough dough in here, you need more money to push it, you need a key player? Is it that simple? Or like, what's happening? I looked at some of the research. I said, at minimum, this should be good research to look at this, because I think it's a viable option for people.
Right. What did that professor happen to be named Dr. Dewhurst?
I think so, yeah.
Yeah, he's a major player in the field. But let me answer your questions. In terms of, you mean what's going on in terms of?
Yeah, why isn't you would think this would be in every academic institution when they say, to my prostate cancer patients, all right, your options are surgery, radiation, and hyperthermia. Why is hyperthermia? Cryotherapy, the opposite is an option, right? Cryosurgery. Right. Why not hyperthermia?
Right. Well, it's very interesting. I will tell you my theory, and it's, again, I don't know for sure, but I'll tell you what I do know. So it's very interesting because what is more well known and what is done in more centers and accepted by more oncologists and accepted by more radiation oncologists, mostly because of familiarity and awareness, although I suspect there's more data, never did a comparison, but there's plenty of data with hyperthermia. And there's also plenty of data with what I'm about to mention, but HIPEC. So heated chemotherapy put directly into the abdomen during surgery, okay, because heat will help that chemo get taken up more. My point is that's done at a number of centers. If you said HIPEC, okay, heated chemotherapy, an oncologist would know what you're talking about. A surgeon, an oncological surgeon, would know what you're talking about. A radiation therapy, radiation oncologist would know what you're talking about. If you say hyperthermia, they might have heard of it, but they often won't know what it is. So Our technology has been FDA approved since 1987. And in some ways, well, when it was first out there, many of the machines were sold to radiation oncologists. They are super smart people, right? So in the early days, many would put a probe directly into the tumor. I mean, I'm surprised they got anybody to do it. And also, if you think about it, radiation oncologists are often referred to, but they really are not the quarterback of someone's disease for the most part, right? That's it never, they really had to check with the oncologist to do that. I'm assuming. I mean, it probably couldn't just, randomly prescribe it for a patient. And so the awareness wasn't really there from the beginning. And then came the NCCN guidelines. Now, hyperthermia was actually part of the guidelines for breast cancer in 2015, is my understanding. Okay. But it was very brief and it just never. So now we use skin probes. It's a much, and we heat to 106 to 109 degrees, right? This is a gentle therapy. We're not burning anything. I'll talk about the mechanism in a moment. But the reason that it didn't catch on, I think, was because it was placed in an area where it was difficult to get it utilized on a regular basis. Had it been put in more so in the hands of oncologists, I suspect that, and had there been a little bit more data early on, I suspect that it probably would have worked its way in because from my perspective, you know, look, as a medical recommendation, because it's such a gentle therapy with a favorable side effect profile, nothing has zero, but it's again, we're heating to just over fever temperatures. And we're approved for all solid tumors. Almost everybody should be considered for hyperthermia, and yet because of that sputtering start, if it doesn't really catch on, as move on, standard of care
Right.
moves on,
Right.
and then if the machines are not, then they don't sell as well, and one thing leads to another, and then it just kind of gets paused
Dies out.
indefinitely, which is what happened. And we're really reviving it. Not that other centers don't have the microwave device, some do, but they use it in a pretty narrow way, I think. Again, that's my impression, because otherwise you'd hear about it way more than you do. So that's my take on it.
So, what are the two technologies that you were referring to earlier that exist for
Um,
hypothermia?
Ultrasound, which is and microwaves, and they're fundamentally different in terms of the frequency and the type of energy, if you will. So we have the same physics as diagnostic ultrasound, which when I have a consultation with patients, a number of things give them a good sense of comfort. And right now, although we are building a referral base of Western doctors, a lot of naturopathic doctors refer to us, and we get direct from patients, right? And so when the patients come in, regardless of who referred them, I just got called from a GYN oncologist nurse who is referring a patient to us because she understands our technology. And when the patient comes in, they're very comforted because, many times women will have experienced themselves an ultrasound if they were pregnant, obviously, and it's familiar to them. So all it is it's at a different frequency. So instead of bouncing off and you catch the picture and that's an diagnostic ultrasound, it penetrates because it's at a different frequency and it actually heats at 10 centimeters below the skin, actually below the thick layer of fat that's right below the skin. So it goes right through that layer and then it starts getting picked up by the tissues. And our ultimate goal is wherever the tumor is, and it just will pass right through the tumor.
Why do you have the ultrasound equipment and not the microwave? Is it better than the microwave?
We have it because that's the technology that is proprietary to our business. We set our business up, and I call it a business because it's a freestanding clinic.
Mm-hmm.
And this way, we're very much an honest broker, right? I don't give chemo, I don't give radiation. All I do all day is hyperthermia. We're not connected with any medical center. Again, this is for better and for worse, okay? Everything has two sides to it. We find it works well because I have a very niche thing that I do. I have done thousands. When I say I've prescribed, and I've done many of the treatments myself early days, but I've prescribed, thousands upon thousands of treatments. So we have an enormous amount of experience. And so because we have that technology as part of our center, that's why we use it. The microwave technology is a very valid technology. I'm more familiar with and I've not used a microwave device because, again, when we set things up, we set it to be a closed loop system where we have the technology and that's all we do. We consider ourselves the leader. I mean, others might consider themselves the leader.
Well,
But
you're the Hyperthermia Cancer Institute. Love the name, and the name
yeah,
says it all. And I don't know
it
of
says it
another.
all.
Actually, I don't know of many hyperthermia institutes, at least in the U.S. So,
Right.
and I've been in the game for a while. And the first name that my good colleague Nacia Winter says, like, you got to talk to Penzone about this. So here we are. So yeah, your clinic. How long you been in business for?
I have been the medical director and then chief medical officer for 6 years. We opened in July of 2018.
Oh, okay.
And yeah, there was a clinic prior to that, but our particular clinic, and we actually just opened our second clinic in April.
Is that
Yeah,
one? Is that one in New York? We talked
yeah,
about that
well,
before
I'm from New
before
York,
recording.
so I'd love to say yes, but our first one was in Santa Monica,
Yeah.
California. The second one was in Irvine, California,
Okay.
both of which are very big medical hubs in Southern California, as is San Diego. And then, there's plenty of medical,
Sure.
institutions all over the place, but next major hub in California would probably be San Francisco.
Wow. Okay. I think I might have told you I came close to going to Irvine with Dr. Jamie Landman, who's the director and chair of the urology department at UC Irvine, but it wasn't a good. Things were even more expensive than they are here in New York. So I was like, why would I move there?
That they are.
Why would I move there? Question for you. I am thinking, when I think hyperthermia, based on what I know, which is, limited, and we're going to get into more detail in a second, I'm trying to think, well, particularly if I'm going to use it in conjunction with anything else, I'm not sure that there is a cancer that I would not use it for. So let's start there. What's a cancer that, if you have, I don't know, pancreatic, it's not a good deal. Is there any cancer that hyperthermia would not be a good fit for?
In theory, no. In practice, yes. So, for example, and it's more location of the body than it is cancer. So the answer to your question is, first of all, just for solid tumors, so not leukemia.
Okay.
The other limiting factor is because we have the same physics as diagnostic ultrasound. When ultrasound hits air, it stops. So if a patient were to have either a lung cancer that was against the chest wall or a metastasis that was against the chest wall, I can treat it. If it's central in the lung and there's an air gap, the ultrasound won't reach the tumor. So that's one constraint that we have.
Right.
Again, that's an anatomical constraint. Not again, we're FDA approved for lung cancer, but we have to be able to get to it. And then anything inside of the cranium, because you've never heard of people getting an ultrasound of the lung. You've never heard of people getting an ultrasound of the brain, although they can do ultrasounds through the temporal bone in certain instances. Neurologists can, to look at stroke and things like that. But for the most part, the skull is a barrier to diagnostic ultrasound. To therapeutic ultrasound, I can heat a skull metastasis. I just can't get through bone because there's a hierarchy in terms of what types of tissue absorb heat the most. Bone absorbs it the most, fat absorbs it the least, muscle is in the middle, and tumor is kind of in the middle with muscle. So we can treat any of the appendages. We can treat anywhere in the chest that's against the chest wall or in the mediastinum. We can treat anything in the abdomen. So, and we can treat breast cancer, breast tissue, obviously. So pretty much head and neck, a lot of data, very, very powerful for head and neck, colon, rectal, ovarian, prostate, pancreas, breast cancer, as I said, head and neck cancer, anal cancer, appendiceal cancer. We do very, very well now, granted, we like patients to call us as soon as they find out they have cancer. That's the ideal time because the earlier we can intervene, the better, like any therapy. And we only treat in conjunction with chemotherapy or radiation therapy. And I'll talk about the mechanism in a minute. But we're local therapy. So again, that's a constraint. I'm very cognizant to make sure patients fully understand what we can and can't do. On the other hand, if you look across tumor types, you've got about, and again, it varies study by study, but call it approximately a 50% increase in complete response rate. And that means tumor gone. Now, let's do the math. If you're getting radiation or chemotherapy and you have a 10% chance of that tumor completely going away, I can make that 15%. But if you have a 50% chance, I can increase that to 75%. So, if you wouldn't mind, I'd like to go through the mechanism so people understand why we're so dependent on the primary therapy. In other words, we're the boost. We're not used
Sure.
alone. We
Once the
boost
cat
those
is
other
out of the
therapies.
box is a little bit more difficult, Joe. So if it's obviously widespread metastasis, and it's a little bit different, right? It has to be
It's different.
its local region.
Yeah, but it's very interesting because these days I spoke to an oncologist recently who said, really, in certain individuals with certain types of cancer, it's really become a chronic disease. Not only has it become a chronic disease, and again, these are things that I've heard and read. I can't independently validate them, but many people are familiar with Moore's law, where every 18 months to 2 years, the number of transistors that you could put on a piece of silicone doubles. So it's been true since the 60s or something like that. Well, there's an innovation cycle in medicine, and apparently that's just as fast or faster. And so my point is, we're accelerating. So now, if we can be part of the solution, okay, and there are a few studies in a few types of cancer that have shown increased survival rates, right? But remember, with hyperthermia, but many of those studies were done quite a while ago. Well, we've come 30 or 40 years since that time, 35 years since that time, right? So now, when I tell you about the mechanism, you'll say, oh my gosh, if that makes a more effective therapy work even better, then sure, in stage 4 disease, what you just mentioned, we are going to, I never say people can or can't be cured. Granted, it's a heavy lift for people in stage 4, and most people with stage 4, do not achieve cure. Some do. And the point is, if you treat the largest tumor burden and you're able to just give them a little bit more runway, okay, where they're not just overtaken by the tumor, right? Then that magic bullet might be a year away, 2 years away, 3 years away. Who's to say? And so for that patient, and that's happened to many patients, for example, with lung cancer, where, when you have targeted therapy, for some patients, even with stage 4 disease, that's a cure. That's happened with melanoma. That's happened, so this is not pie in the sky. I'm not trying to give people false hope. I'm just saying, what are you going to do? You only have a choice, either fight it or not. And that's an adult's choice to decide what they want to do in terms of the aggressiveness of pursuing cancer. Most people want to fight it hard. And, we're a piece of that solution, just a piece of it, but we're a nice piece of it because we're gentle on the body and we help the underlying therapy work better.
All right. So let's talk mechanism.
All right.
How does it work?
So,
Thank you for watching the Dr. Geo Prostate Podcast. Take a proactive step and improve your health and vitality with the Prolon Fasting Mimicking Diet FMD, a 5-day, plant-based program developed by Dr. Walter Longo. Designed to mimic the effects of fasting without the challenges, Prolon helps activate autophagy, reduce inflammation, support weight management, and promote overall longevity, all while nourishing your body. As a special thank you, you can access the Prolon kit for just $148. Use the link below to get started. Empower your journey to better health today.
there are 3 mechanisms, okay? The first mechanism is when cancer forms, it's an abnormal mass of cells. And so many of the structures in it don't form properly. And cancer is so dichotomous. Any given cancer cell, because it's abnormal, is potentially quite fragile. Any tumor, believe it or not, is quite fragile. The problem with cancer is that it is like supercharged evolution, right? Because it just accrues more and more mutations. And most of those mutations, just like in evolution, don't work. But some of them make the cancer stronger. So, for example, since solid tumors don't form blood vessels well, by and large, at the center of the tumor, those blood vessels collapse. Now you've got a situation where you've either cut off the oxygen or you've made it really kind of low oxygen tension, just not a lot of oxygen, hypoxemia, right? So a lot of times the center of the cancer will die off when that tumor is very, very small. All you need is one mutation in a cell for that cell to evolve, figure out how to live at low oxygen tension, and now it fills it right in. And now that's why if I did 100 biopsies on a tumor, as you know, the genomics, what those genes are expressed, they're going to be different in all 100 biopsies of the same tumor because cells keep evolving in different areas. That's why they're so hard to get rid of all of them. But let's get back to the mechanism. So now you've got a hypoxic environment at the center of the tumor. Chemo can't get there very well. And I didn't really understand this until I got into the field. But although you definitely get cell killing when the chemo's going in, you get cell killing when you're on the table with radiation, especially with radiation, so much of that cell killing happens later because radiation takes oxygen and it causes free oxygen radical formation on the DNA and it damages the DNA. Now, if the cell is not killed while you're on the table, that cell stays alive. And when it goes to divide, if the DNA is damaged, it goes into programmed cell death. Every cell in our body has the ability to repair itself. If that weren't true, we'd all get cancer the first week of life because you can't have, billions of base pairs replicating and not have some error in there. So mechanism one is we increase the blood flow, which does two things. It allows more chemo to get to the center of the tumor, just plain old access, and it allows more oxygen to get to a place that doesn't necessarily like oxygen, by the way, but can then let radiation use that oxygen to kill tumor cells. Okay? Excellent. And so that's mechanism one. Mechanism two is every enzymatic reaction is both temperature and pH dependent. So when we heat the area, we slow down the repair of the DNA that I talked about. And there are types of chemotherapy that result in damaged DNA. And there are, and radiation, as I mentioned, one of the main mechanisms is relying on damage of the DNA. So we now sensitize radiation to work better because we give more oxygen substrate because radiation typically is not as effective at the center of the tumor. Once we infuse oxygen in there by opening up the blood vessels, radiation becomes much more effective. Chemo gets to it, radiation gets to it, and we then slow down the repair of the DNA. So when that cell tries to divide, it goes into programmed cell death. That's mechanism two, slow down DNA repair. Mechanism three, bit of a head fake, right? Because even though we're heating in an 8-inch by 8-inch or 4-inch by 4-inch, we have two applicator head sizes, right? Area. So we're treating the tumor. We have no known adverse effects around the tumor. So we actually want to treat the area around the tumor because a lot of times that's the way cells start to spread. But the tissue in the area that we're treating thinks there's a fever going on. So it reacts to the heat by secreting something called heat shock proteins. And heat shock proteins are the way that a fever supercharges the immune system. What do I mean by that? Well, it takes the antigen presenting cells, and now the abnormal proteins that are inside of the cancer can be molded onto that antigen presenting cell. It can present it to a T cell, and the T cell can now be educated. That's abnormal. I'm going after that tumor. T cells and natural killer cells. So It actually works as an immunogenic agent. Now, that all sounds good, but like every other therapy, we work better in some people and less well in other people. And I can't tell you ahead of time who that is, very much like an oncologist does his or her best to pick the right chemo regimen. I mean, believe me, they're trying, but works better in some people and not as well in others. And sometimes we know why, and most of the time these days we don't. We're on the precipice of knowing why, but those are the mechanisms that hyperthermia is very, very well worked out. And that's another reason I think that gives people comfort. We're very time intensive because you have to come to us each time you get radiation. And in chemotherapy, we kind of individualize the treatment regimens, but you still come in quite often, and way more often than you're getting the chemo. And so, we understand that is a big ask, but in those patients, and there are many of them, not all of them, but many of them, and they get that next PET CT scan, and it shows, that the tumor we're treating is going down, or hopefully all of them do. I mean, look, I hope all of them do, but a lot of them, the one we're treating is going down. It's like, yeah, we're helping that one. And so then a lot of times, and we've had a number of patients who have stage 4 cancer where we're chasing the tumor around month by month, 2 month block by 2 month block. I mean, again, if we're working, we're working, and we don't have to convince patients. Believe me, they want to come back if they're getting
So
good results.
how many treatments on average, or does it depend? And does it depend on what? So how often do they have to go weekly, monthly? How does it work?
Yeah, so during the time that they have radiation, they come every day for the radiation. So each time they have radiation, they come for hyperthermia. And
So if they have
nobody
radiation
knows.
for 5 days, they go for 5 days. If they have radiation for 40 days, they go for 40 days.
Correct. Correct. They have the option to go for a period of time after the radiation, although that there's no data to support that. One of the reasons why after radiation we don't get a scan right away typically is because, again, until that cell goes to divide, it doesn't really, it's still alive. It's cell death. So we often treat a little after the radiation and a little bit after the chemotherapy. So for the chemotherapy, many of the studies were done twice a week. But remember, a lot of those early studies required, you to have a probe in the body. So we often treat, it depends on the patient, depends on the regimen, depends on how often they're getting it. But we could treat up to 6 days a week or fewer days per week, depends on the patient, depends on the clinical circumstance. And we try to do our best to individualize it with the patient, given the type of cancer they have, how often they're getting chemo. The logistics matter. I mean,
Yep.
it takes time to get to our center. We're
Yep.
we're one physical place, just like a hospital is.
Yep.
You got to get there. So,
And
so
right. So as it relates to chemo, probably twice a week for the amount of time that they're going to go undergo chemo
or more,
or
twice a week
more.
or more. Twice a week is a minimum for us.
Okay.
They used to be worried in the old days about thermoresistance, meaning if they heat too much, you might get resistant to that. But we don't worry about that anymore. That's been debunked. So the more the better. The more the better. If they can come 6 days a week, that's actually preferred during the time they get chemotherapy. And again, we recognize how big an ask that is, but 2 days is a minimum, 6 days is a maximum. So it depends.
All right. In the world of cancer, certainly even in the world of prostate cancer, right? Because we have to admit that things are, we are in the trenches, and sometimes we have to think outside the box, right? And the patient is informed and well informed. They have access to a lot of information. Some of it is not great information, but some of it is. And so they're actually asking better questions. Here's why I say that. In terms of thinking outside the box, for example, which I have sent people to you and Dr. Parmar, the way I see it for prostate cancer, now we're going to dive into prostate cancer specifically. They probably going to do their radiation, let's say, at their home state, likely, and then say, look, can I do hyperthermia simultaneous? Well, not simultaneously, but either after radiation or before radiation. And so what would be the answer for that? And what's the benefit? What would be the benefit as best as you can gauge?
Sure. So I'll tell you that for the vast majority of patients that we treat that have radiation, even if they come from out of town or if they don't, they end up getting radiation close to us
Mm-hmm.
because we have many. I mean, we're fortunate. I'm in the Los Angeles area, so we
Yeah.
have
Many
millions of.
places.
I mean, it's in the top five, I would say.
Sure.
Places like New York is. You know, if you had to get sick, I mean, where are the specialists? They're in the big cities, and so the point is, we have plenty of people to be able to treat them. Now, you raise a good question. What happens if you either don't want to do that or you can't do that? I think in theory, as I was mentioning to you before, there's probably some benefit to treating after the radiation is done. It hasn't been studied, so I don't want people to walk away thinking, oh, I'll just do that and it will be just the same. I wouldn't look at it that way
Yeah, that's why I
because,
prefaced it with
yeah,
out of the box thinking. I know
sure,
this hasn't been
yeah,
looked at, but look, if you ask me, I've seen 8,000, I literally have seen 8,000 prostate cancer cases. I could tell you out of the box thinking that may sound, pretty good. You've seen many patients
yeah,
as well. So when you're an expert like yourself, I'm actually very interested in some
yeah,
of the things that are not quite studied, but coming from you, the expert, I would take it for some face value.
sure. Yeah, so my medical critical thinking tells me that for 1 to 3 months after radiation is done, for 1 to 3 months after chemotherapy is done, there is a potential benefit to getting hyperthermia because we slow down the repair of the DNA.
Mm-hmm.
So, again, I'm going to double down on not studied, just my thinking is there is a potential benefit out of the box thinking, which is what you asked for,
Mm-hmm.
and there's a potential benefit to doing that. It makes sense medically. Will it work? Do we have any data? Do people? I'm not even sure we've really treated anybody in that fashion, to be honest with you. But if they said to me, look, the patient, they absolutely will not come down to you for radiation. They need it in their home state. They want it in their home state, but they're willing to take a vacation for a couple of weeks in Santa Monica. Would you treat them? Sure, I would treat them. I would also tell them just what I'm telling you, very open with patients that look, there's no, and I'd tell them on the phone, by the way, before they got on the plane, there's no data, but we have had patients come in certain out of the box therapies. For example, we're not used alone. Well, there are some patients that have cancer where they literally, and they have rare cancers typically, where they have stage 4 cancer and they say to me, Dr. Pinzone, I have no option. I understand what you're telling me. There's no studies. And I say to them, you know what? As long as you know, you understand, I think it's medically reasonable to try in you if you have. And so we've 1 or 2 patients, we've used
Sure.
hyperthermia alone.
Sure.
And, again, out of the hundreds and hundreds of patients we have, that's not the norm. But again, you have to be able to pass the face test, I think, with yourself and with the patient.
Yeah.
Now,
Yeah.
just as I've told you on the phone when we spoke last time, I've had a patient come up to me with, stage 1 endometrial cancer, and she wanted to use hyperthermia instead of surgery. I said, no, 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 that we don't do. Don't do. That's not an appropriate, because we don't use it as a substitute when another therapy. I mean, it's that patient's right not to have surgery. That's her choice, her body, that's all her. But that's not a good way to use hyperthermia alone, because
And is
that
it
will
not a good
figure into,
way?
yeah.
Is it so? I'm trying to think, is it not a good way because it's not FDA approved that way? Or is it not a good way because the technology itself cannot be used? In other words,
Yeah.
let's just say if it's approved in the US, and would you be surprised if they looked at it as a primary treatment for cancer?
So here's the thing. The FDA does not tell me how to practice. If I wanted to, I could have every single patient who called me come in, no matter what. I could just say to them, because so much of it is left up to the doctor, what I think is medically appropriate. Okay. And so if I say it's medically appropriate and I honestly believe it, right, that comes down to what's in my mind and my ethics. If I honestly believe it's medically appropriate, then I will use it to treat them, and I can. But I don't think widespread use of this alone, even though that would build the awareness of hyperthermia, it's not the right thing to do. So again, the woman with the rare cancer came to me who had no options. I thought it was very reasonable to treat her because we were on the same page and she had no other options. But I don't want to be used in substitute of something else because that's just buying into something where it's kind of, you know, being positioned as, yeah, this could do something. And there's really no evidence that it can. So it's all, so much of it is left up to doctors' judgment about what to do. And I really try to be very, very judicious about what I do, but I also don't want to hold back, which is why our center treats so many people compared to the average center that has a machine. I mean, we're doing thousands of treatments a year. That's unheard of, but they're all appropriate treatments, in my opinion. And again, that's my point. Is just as you said, you've got to use your own judgment of, you know, the vast majority are straight down the middle. They're on chemo, they're on radiation. They're not getting it after chemo, they're not getting it after radiation. Some get it after. Every once in a while we do it alone, you know. So again, I'm right there with you, Gio. I think that you got to do what you think is right, but you got to be really, really thoughtful and
Yeah.
open with the patient.
Well, you may know that there is something called high intensity frequency ultrasound
Yes,
as a
HIFU.
treatment.
Yeah.
HIFU. Yeah. So I'm thinking, okay, maybe HIFU is a location, is a certain probe that's inserted either through the urethra, it's called TOSA, or through the rectum as HIFU. And then they send ultrasound waves at very high intensity to the actual tumor. Well, the mechanism sounds very similar. How it's done is different, but the mechanism sounds similar. So that's why, I'm just thinking along those lines.
Well, it's a very good thought. I've had people ask me that very question. And even though I don't understand a lot about that technology, my understanding is, and you probably know more than I do, but with HIFU, you actually are disrupting the tissue. So you're going in and you're actually physically breaking up tissue
Yeah, you
and
are.
you're damaging the tissue.
You are.
We're
Yes.
not damaging the tissue. We're changing the
Environment.
biochemistry. We're changing the molecular biology of the tumor. We're
Understood.
not burning or hurting anything.
That's a very important distinction.
Yeah. Yeah.
Yeah.
Now, it's not to say that we don't have any direct cell killing, because we do have some evidence that we have some, which
Sure.
is why occasionally I will use it alone, but it's not a standalone. And HIFU, I know, is coming to the fore. It's still, not used a lot. And long-term studies, I think, still need to be done. Again, I don't know a lot about that
We've
therapy.
had about 5 episodes with the best of the best on focal therapies, and much of it includes HIFU and TULSA, which is the one that is applied through the urethra. I know you have so much time in your hands, so I'll send you those links. I'm actually kidding because I know how busy you are with your practice. But I'll send them to you anyway. Maybe there's one or two that you'd be interested in, because
Sure.
there
No,
are
seriously, I
experts
love learning about other therapies. But yes, I do have limited time. But yeah, no, it's a great thought that you had, and it does make good sense. But I think in practice they're fundamentally different.
All right, so
aiming to do different things to the tumor.
I have another case scenario here for you, out of the box.
Sure.
So regardless of age, I had my prostate removed. The pathology report shows that is a Gleason 9, so it's aggressive. There is no evidence of metastasis of any kind. So while there's a Gleason 9, there's no evidence that, based on PET CT scans and MRI prior to my prostate being removed, that there's any cancer outside of the prostate. Okay? Still a Gleason 9. I want to do hyperthermia after that surgery, just kind of, as an insurance, to make sure that if anything is there percolating, that the PET scans, some micro metastasis that the PET scan didn't pick up, I want to kill it. That sounds reasonable to me.
Yes, that is reasonable.
What are your thoughts?
Yes, that's reasonable. We have done that in select cases, exactly as you said it. And again, I don't have to double down because I've been doing that all show. But, I will tell the patient there's no data on this, but that actually does make sense. There's really nothing else they're going to do. They're going to be on, let's say they're going to be on Lupron or whatever, to an androgen blocker.
Actually, in that particular example, Joe, I want to prevent Lupron, right? So if I do get a recurrence of PSA, the next thing that I'm going to get is Lupron. And I don't want to be chemically castrated if I can avoid it. So I'm saying for as an insurance policy, there's no evidence that there's any cancer. There's a Gleason 9. And typically, within some period of time, there's a PSA recurrence once there's a high percentage that they're going to get a recurrence when they have a Gleason 9. Maybe a little hyperthermia can kind of reduce that risk.
Yeah, it's possible. Again, there's some data that says that we have some direct cell killing, and I think we don't have any harm to normal tissue, and we do increase blood flow to that area. And we do have some direct cell killing. So I think that is a very reasonable situation where, as long as all eyes are open and we hold hands on this issue, that's a very reasonable way to use hyperthermia, with making sure that we manage expectations that could still come back if you do nothing, could still come back if you do lupron.
And then if you combine that, so what I do, I don't have the fancy tools that you guys all do. What I do is aggressive lifestyle intervention. So I make sure that they are exercising as prescribed, dietary and things like that. So when you combine everything, I'm saying, wow, I think there's significant, even oftentimes when they have Gleason 9s, for example, and they do these protocols, they oftentimes don't get a recurrence. And if they get a recurrence when they do some of these natural protocols, lifestyle protocols, if they do get a recurrence, it's so slow that they may not need that next treatment. I see that all the time. And I'm saying, wow, if you combine yet another tool like hyperthermia, that may be golden.
Yeah, it may be. And again, I would evaluate that person on an individual basis, but I think that there I do agree. Not that I don't disagree with anything that you're saying, but there I do agree that it makes sense to, as an insurance policy, to think of it that way, even though we understand it may not be, but it's not an unreasonable thing to think
consider.
about.
All right. Everything sounds too good, Joe. And anything that sounds too good to be true is oftentimes too good to be true. I feel like, man, I don't even know if I have cancer, but I want hyperthermia. It sounds so good. All right. Side
It's
effects.
funny. Yeah. Well, no. So let's go through that. So there's no free lunch. Okay.
Right.
Let's face it. Now, when we're talking about purely heat derived issues, reddening of the skin is common. We don't heat enough to get a third degree burn. That I've never seen. I have seen in a handful of patients each year we'll get blisters, and a handful of patients will get a very specific heat rash. Now, the blisters are sometimes from the hyperthermia. We can heat enough. So, like, what I always tell people is, when you're first undergoing it, this is not a hero's journey. Remember, we're not burning anything. We're changing the physiology. We're changing the molecular biology, the biochemistry. So what I want you to do is think, gee, if my hand were under hot water, would I want to remove it? If you would, ring your call bell. We'll come in, we'll change the settings on the machine, because we can cause a burn. And then there's the patients that's getting radiation where, you get some radiation induced skin damage, and we usually put a little gauze over it. We continue to heat and we seem to be okay. And then there's the one-off things, right? So there are patients who will feel some warmth an hour later, or if we're treating directly over the stomach, which is unusual, they may get a little nausea. But honestly, I think it's because we're heating to 106 to 109, and it's so localized, and we have such good nurses and such good control. And now it's a little trickier post mastectomy, right? Because there's not really a lot of subcutaneous fat. You're almost basic, and sometimes, let's say you have a skin metastasis. We have this or skin recurrence. We are treating right over bone. So we do have a deep and a superficial setting. In that situation, superficial might be best tolerated. So I guess another way you can think of an adverse event is it's just not tolerated. I'll give you an example. Liver's very common organ that we treat. The majority of patients do not have a problem, even though their ribs are there. Now, maybe it's because they've got, some tissue over the ribs or what have you. Liver happens to be an easy organ to treat. It's homogeneous, it's soft, it just heats really easily. But we can
even though there's ribs around there, and that doesn't interfere with the transference of the heat?
It probably does, but so my point is, we have to treat in the intercostal muscles, the muscles that are between the ribs. There's enough room to get that heat in there.
All right.
But there are an occasional patient where they get so much sensitivity to the ribs that we really can't treat that area. But that's highly unusual. Most of the time, if they are getting any rib pain, and there are some people that do. So again, you asked about adverse events. That's one of them. We can usually, the way our crystals are set up that generate the ultrasound is they're set up either on a 2x2 in the small head or a 4x4. So we can control the energy to 16 different quadrants individually. So we can get around that sensitivity by closing down the quadrant that's over a rib, and then that will go away. But really, many patients sleep through the therapy. You know, Gio, when I started this, it took me, even though I read the literature before I started it, I made sure I understood what the technology was about. I did it. I mean, I was skeptical for like 6 months. I was like, does this really work? You know, here's the thing. I'll give you an example. So I just presented a poster at a scientific session. There's the International Society of Thermal Medicine, I think it's called. But yeah, the one I presented at Oncology, right?
Integrative Oncology. So SUO?
SIO,
SIO, I'm sorry.
the
SUO is
Society for
Society
Integrative
of Urological.
Oncology.
Okay, SIO, sure.
Yeah.
They've invited me to give. It's just been too crazy. So yeah, it was not that long ago, actually. I think
Exactly. And so we had a patient, it was a case report, right? She had ER positive breast cancer, very large. By the way, Society for Thermal Medicine. I was just blanking on that for a
no
moment.
worries. Yeah, thank you.
So there's a journal of International Journal of Hyperthermia, by the way. So there's a journal just dedicated to hyperthermia.
Beautiful.
And so in any case, this lady came to us and she had a breast tumor fairly large and she had lymph node metastases. So that's a situation where we had a choice. We could either treat the breast tumor, we could treat both. We would then have to charge her out of pocket because her insurance paid, right? Or we could alternate. What we chose to do, because she was getting neoadjuvant, that is before surgery, as you know, chemotherapy. So we said, you know what, let's hit the breast mass with heat because that's the largest mass that we have. And the breast mass, when they did the interim, halfway through the chemo, they did a PET CT scan, no evidence of disease. The axilla, which we were not treating, persistent disease. We then turned the heat on the axilla, gone. She had a double mastectomy and lymph node dissection, and they could not find any trace of cancer. So that is some evidence. I would not put that in front, again, I put it in front of an audience for what it was, a case report. It's not a controlled study.
Sure, I understood.
But she was her own control. So because where we were putting the heat disappeared, and then where we put the heat disappeared, right? It hadn't disappeared without the heat. I'm like, okay, the heat probably made a difference in her. In every patient, of course not. But in her, it really did. And so, it was fairly well received for what it was. Again, case study, but it was pretty cool. And it's cases like that, or the case where the oncologist says, I've never seen this in my career, where you're like, okay, I think we're helping that patient. And so I think we help the majority of patients, but I think we knock it out of the park, maybe 1%, 2% of the patients that come to us.
Anything that, so most people watching this concerned or are focused on prostate cancer. Anything else that we haven't covered that they should know as it relates to hyperthermia for prostate cancer?
Yes. So I'm glad you asked. The prostate is the prostate and the breast are probably the easiest organs for us to get access to heat because they're although the prostate is not external, I'm going to describe to you how we do it. Breasts are, on the external portion of the body, and so very, very easy. And there's a lot of fat tissue in the breast. So again, an easy organ to heat, and you can palpate the tumor, so you can't miss. Okay, prostate. The way we treat it is the man will be in frog leg position, and the perineum, that part of the body that is right between the testicles and the anus. As they're in that frog leg position, it'll bring the prostate right down into the perineum. So the way it works is we have an applicator head that has a crystal, and then there's a cooled water bolus. We put gel on the place we're going to heat, and then we put some temperature probes, and then we put some plastic, and then the cooled water bolus goes on the plastic. So when we treat in the perineum, We have a direct line, I was going to say of sight, but treatment waves,
Yeah.
ultrasound waves to the prostate is right there.
Yeah.
And again, the perineum has a fair amount of fat in it. So right on the other side of it, prostate's right there. So
Yeah.
we could just nail it. Very good access to the prostate.
Oh, excellent. Excellent. And no specific side effects that are different from treating other cancers when you do hyperthermia for
No,
prostate cancer specifically.
no. And, interestingly, there have been cases where, very much like with the phosphodiesterase 5 inhibitors, where, they were looked at for one reason and then they realized that men got erections. You can actually increase the blood flow to the area and it can actually cause an erection. So,
Whoa.
although I wouldn't call that an adverse event, it's
Right.
nonetheless, it's just
Yeah,
something to
that's
know
the
about.
story of Viagra, isn't it? Yeah.
Yeah, yeah, yeah.
Wow. Maybe you're onto something that I don't want to hear in just a few years that, well, no, the practice is no longer for cancer treatment, is for hyperthermia for erections. That
I think there are easier ED treatments.
Hyperthermia Erections Institute.
Right.
Joe, what happened? It used to be the Cancer Institute.
There
Oh,
was a
Geo.
C in there. Now there's an E.
The side effects were
Yeah.
significant.
Yeah, exactly. Yeah, no, you don't want a hyperthermia machine in your bedroom. There's there are much better ways to treat erectile dysfunction than
That's right.
hyperthermia. But look, I will tell you, partly because we have so many treatments that we do with patients. They come in as patients, they go out as family. I've never gotten really really close to patients, especially the nurses.
Yeah.
I mean, I see patients in the consultation in every fifth treatment. So yes, I get to know them. I care about all my patients, but the nurses are like, they hear their life story. They're with them for an hour every day often. I mean, it's a healing environment, and I'm in California, okay, but I'm from New York, right? I don't want to get too frou-frou here. But honestly, when you can come into a healing environment and
Sure.
you can take an hour out of your day and that you actually, sure, you don't like the drive, it's California, it's busy traffic, but when you get here, it's a nice environment, it's an
Oh, good.
hour out of your day where you chill out. That's not, that's an important part
Absolutely.
of what people feel. They have someone to talk to. Okay, we don't have a trained therapist, but our nurses are highly compassionate. I
Yeah.
mean, it's just one of those things where it's like you get really close to patients. And I think oncology nurses, we don't have oncology nurses, but we have only RNs or LVNs treating patients. You don't have to have a nurse. We just choose that. We feel that that's the minimum qualification to treat a patient. And we have, it's just a really nice, it's just been so nourishing to the soul to be part of it. And I think that's why I just feel so lucky to have found this.
Yeah, me too. I feel lucky that you have found it because I think it helps a lot of patients and it will help a lot of my patients that will end up going to you. So I'm grateful for your work as well. Dr. Joseph Penzone, originally from New York, or at least from the Northeast, and now in California. Joe, how can people find you or your clinic?
Sure. Well, you can just Google Hyperthermia Cancer Institute. Our website is hcioncology.com, and just give us a call or send us, there's a way to interact through the website, or the number will be on there. And you can just give us a call, and please call us as soon as you possibly can, that after you have cancer, because that's when we can do the planning
Sooner better.
with you.
Yeah.
Sooner is better.
Joe, thanks so much. I really appreciate your time here.
Thank you so much. Always a pleasure. Very
you.
nice talking with you.
Thank you, everyone, for watching this yet other extraordinary episode of the Dr. Geo Prostate Podcast. Look, these are the things that you may not know about. That's what we deliver. Things that, if you're going to be a self-health advocate, which is what we call our, those individuals that listen, that are part of the Dr. Geo newsletter as self-health advocate, and you're going to be part of that shared decision-making. Everybody talks about it, right? You need to know what you're talking about. And you need to be proactive. There's no other way. And that's the way. So here we have yet another expert on hyperthermia. So I hope you enjoyed it. I know you did, found it valuable. This is Dr. Geo signing off. I'll talk to you next time. Take care.
We hope you enjoyed this episode. You'll continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more. The Dr. Geo Prostate Podcast is here to provide you with information and support on your prostate health journey. We are introducing our exclusive membership where you can get even more value from every episode. Every episode comes with detailed show notes, breaking down the key points so you don't have to take notes while listening. You'll also get curated transcripts so you can read and revisit everything you just heard, perfect for learning at your own pace. And for every episode, you'll receive a handy list of resources, products, links, studies, and tools mentioned in the show, all in one place. That's not all. Members also enjoy special discounts on hand-picked products to support their health and wellness goals. And there's more. Members get exclusive access to Dr. Geo's monthly Ask Me Anything, where he answers questions submitted directly by the community. All of this for just $19 a month, or save 20% when you pay annually at only $182 a year. Smarter listening, deeper learning, better health. Join the Dr. Geo exclusive membership today. Start getting more from every episode.
Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.